Welcome again to the second joint webinar between the chapters of the American College of Cardiology in Argentina and New York. This is our second effort in this regard. The first one done last year was extremely successful as it provides a forum for discussion about interesting cases literally across the equator and for a fruitful exchange of information and opinion about what to do with cases that are often very difficult. My name is Julio Panza, and I have been chairing this relationship that started quite a few years ago at my Westchester Medical Center. And for this webinar, I am joined by Dr. Srihari Naidu, who is at my institution, and he's an expert in hypertrophic cardiomyopathy. Dr. Mark Marinescu from the University of Rochester Medical Center, who's an expert on pulmonary embolism, and on the Argentina faculty by Dr. Mirta Diez from the Cardiovascular Institute of Buenos Aires, and Roberto Colque from the Sanatorio Allende in Cordoba, both of them in Argentina. The format of this webinar will be the same as the one that we did last year, and my main job will be to make sure that we stick to the agenda, which is very tight. We definitely will finish on time, and we have allotted about an hour and 20 minutes. Last year, I remember that we even used less of that time. Well, everybody's busy, and I think the best time to make this fruitful and to make it an interesting experience is to make sure that everybody stays on time. So what we're going to do is first have a presentation from the New York chapter, and I will announce the presenters in a moment. And then that presentation will be left open, that is without a conclusion of the case. And then we will invite the faculty from Argentina to discuss their approach of what they would do in a situation like this. If we have time, we will open the chat line, and if anybody in the audience has some questions, you can direct those questions to the chat box. And then we will go back to the presenter and then have a presentation of what happened to the patient, the conclusion of the case. And then we will do the same thing with a case presented from the Argentina side. In between, we will have sort of an intermission, and another very important part of our relationship has been the facilitation of rotations by Argentina residents in cardiology at New York hospitals, and we will have the two trainees that rotated through hospitals here in the last academic year have 5 minutes each to talk about their experience. So without further ado, we're going to begin then with the presentation, the case from the New York chapter. Dr. Jean-Pierre Iskandar will present the case, and I will be moving the slides so that we'll make it more simple. So Dr. Iskandar, please go ahead.
Thank you very much, Dr. Panza. Good afternoon, everyone. My name is Jean-Pierre Iskandar, and I am a general cardiology fellow at the University of Rochester Medical Center. And I would like to present a case on PE, pulmonary embolism, today. I'd like to thank the committee, the Argentinian chapter, and all of the faculty and staff for making this happen today. So I'd like to start with the case report. It was actually a 61-year-old female who presented to an outside hospital ED, and she had a past medical history of asthma, COPD, depression, type 2 diabetes, hypertension, GERD with esophagitis. She had remote history of hepatitis with treatment, migraine and neuropathy. She presented for the complaints of chest pain, shortness of breath, and lower extremity pain. She had severe pain in the right mid-calf a week prior that had persisted, along with some swelling. Her hemodynamics were notable for hypoxia. As you note, her SpO2 was anywhere between the 60s to 80s, averaging in the 70s, and she was tachycardic. Her heart rate was in the 130s. Additionally, she was normotensive, blood pressure 120s, 130s, systolic. Physical exam notable for painful palpation to the right calf with slight discoloration and some swelling. She had poor inspiratory effort. Her heart sounds were not notable for any murmurs, but she was tachycardic.
I think I just found.
Yeah, please mute your phone if you're not speaking. Thank you.
She was unable to tolerate a non-rebreather or BiPAP. She was, in fact, very restless and very anxious. At the outside hospital, the decision was made to intubate the patient, given her persistent hypoxemia. Shortly after intubation, repeat hemodynamics were consistent with a heart rate in the 80s and a systolic blood pressure, in fact, in the 160s. And I wanted to show you guys some of her labs when she presented, and those labs were before the intubation. Her CBC was grossly unremarkable. Her BMP was notable for severe hypokalemia with a potassium of 2.7. She did have an anion gap of 19. And then her ABG was consistent with a pH of 7.51. And then a PaO2 of 49 with a low PCO2 of 27. GI liver profile was notable for an elevated ALP at 119. Lactate, worth mentioning, was, I believe, 4.5. It's cut out in this slide, but it was 4.5. I wanted to point your attention to her initial presenting EKG. As I mentioned, her initial heart rate was in the 130s, and it was thought to be 2-to-1 A flutter, and it was consistent in the 130s. And then shortly after she got intubated, that she most likely came out of it. I wanted to show a few slides of the CT angio. Here we're noting of some axial views. And you could see not evidently, but if we keep scrolling through, I unfortunately don't have a clip of this per se, but from the images that you see, we're describing or we're looking at a saddle embolism on the right-hand side. You see some additional clots on the left and the right PA. And then if we can move towards the next slide. Those are coronal views that show severe clot burden in both the right and the left PA. And not only did we see saddle PE, but we see clot that extended all the way through to the lobar and segmental branches as well. Additionally, which is not portrayed in the picture, is evidence of right heart strain on CT as well. So a heparin drip was immediately initiated, and the patient was transported to an advanced center, and that's where she was transported by air to Strong Memorial Hospital for further care. Her hemodynamics at that point in time when we saw her, blood pressure of 117/79, heart rate maintained in the 80s. But unfortunately, her SpO2 continued to be low in the low 80s while on 100% FiO2. The cardiology fellow obtained a POCUS at bedside, which revealed a markedly dilated RV with severely reduced function. The LV was small in size.
Well, thank you. I really think that in a way this is not a diagnostic dilemma, right? But it's a patient that I would say is treated in many different ways at multiple different institutions. So I think it's a great case to discuss what we would do in different settings. So Dr. Diez, maybe you can start. Tell us what you think about this patient, and in particular, what do you think would have happened to this patient if he had presented or she had presented at your institution?
Okay, thank you so much for the invitation, and thank you, Dr. Iskandar, for sharing this challenging clinical case. Well, as you say, this is not a challenge in diagnosis. This is a patient with a high probability of PE. And CT angiography reveal a significant thrombotic burden with bilateral involvement of main, lobar, and segmental branches of PA and dilation of right heart chamber. I think that this CT also allow us to rule out other causes of severe hypoxemia, because respiratory failure refractory to mechanical ventilation is not so common, and we can think another causes like right to left shunt through a foramen valve. Of course, thinking about the risk of this patient, she is in an intermediate high. If we use simplified PESI score and the presence of severe ventricular dysfunction, but even she is normotensive, the presence of right ventricular dysfunction was associated with an increased risk of death and cardiogenic shocks. And additionally, this patient exhibits elevated lactate, indicating tissue hypoperfusion. In my opinion, this is a patient between a stage B to C of the SCAI classification of cardiogenic shock, closer to stage C, and because of that, I understand this patient as a high risk, require an early and aggressive reperfusion therapy. Of course, systemic thrombolysis lowers the risk of death, but increase the risk of major bleeding, as seen in the PATO trial, and this mix of risk and benefit has limited the use of systemic thrombolysis to the highest risk patient. The approach we will take at my center is catheter-directed therapy plus thrombolytic. Of course, I understand that the evidence of this approach is not exactly guided recommendation, but because it's based on single-arm study using surrogate endpoint. However, we use catheter-directed therapy as an alternative for patients with decreased risk of bleeding, or as upfront combination therapy with thrombolysis in patients with intermediate high risk or intermediate high or high risk. The FLAM study show a lower rate of in-hospital adverse outcome compared with historical reported, and they seen a hospital mortality of 2%. I prefer an upfront combination with catheter-directed therapy because the large thrombotic burden that this patient presented in the CT. And if the patient is going worse despite all this therapy, we'll put her on extracorporeal life support like ECMO.
Thank you. Dr. Colque, what do you think about this case? And again, what would be done at your institution?
Okay, good afternoon. Thank you for the presentation. Nice and challenging case for the treatment. Of course, not challenging diagnosis, but of course the approach. At the initial, the patient experienced a severe hypoxemia. And regarding the blood pressure and the heart rate, I have a little difference or disagree with Mirta regarding the classification in this case, because despite she has no low blood pressure, because there is one register of 160 and the other register 116, the patient is previous hypertension and not taking medication. And probably if she is under 40 or 50 millimeters than the register of blood pressure before. But of course, it's a question of thinking. I put this patient in a high-risk discussion. We have not biomarkers here in the presentation. However, of course, you will present after. With the severe hypoxemia, I totally agree that using in advanced therapy, we have experience with advanced therapy with catheter-directed thrombolysis. We have the chance, despite of this patient has no high risk, apparently high risk of receiving systemic thrombolysis. We have a nice, very elegant experience with directed catheter thrombolysis. We have not the chance of embolectomy or thrombectomy. We have not the devices, but also, yes, regarding the direct thrombolysis. And if the hypoxemia does not resolve, of course, I mean, we have the possibility of using ECMO. Okay, that's my opinion, and thank you for the hearing.
Well, thank you. Why don't we move on to the to what happened? It seems that there's agreement between the two Argentinian faculty discussants that catheter-directed therapy with or without thrombolysis would be preferred. So, Dr. Iskandar, back to you and tell us what happened. And then we will ask Dr. Marinescu for his opinion.
Thank you, Dr. Diez and Dr. Colque, for your contributions. So we do have a PERT team at the University of Rochester. We're lucky enough to have kind of a multidisciplinary decision-making capabilities. PERT team approach was pursued like it usually is. And the options at that point for this specific patient included systemic thrombolysis, catheter-directed thrombolysis, catheter-directed embolectomy, and ECMO placement. And the patient was felt to be in normal tensive shock. However, given how stable, relatively stable she was, a catheter-directed embolectomy with ECMO backup was pursued. And that's where we transferred the patient to the cath lab from the ED. Both venous and arterial groin accesses were obtained. And the systolic blood pressure via the groin sheath was noted to be much lower in the femoral artery than it was in the upper extremities, which made us think that there could be something, some sort of a blockage in the, potentially in the aorta. And hence an aortogram was pursued, and that is when we noted a filling defect, and I will show the image, an occluded infrarenal aorta. Nonetheless, a pulmonary angiogram was pursued, and bilateral acute massive pulmonary embolism were successfully treated with pulmonary embolectomy. Shortly after the embolectomy, the oxygen saturations improved drastically from the 80s to the 90s. I'd like to show some right heart cath numbers, and then I'll show the images. Just wanted to point out a few things. Baseline right heart cath numbers before the embolectomy and some numbers after the fact. For example, the mean pulmonary artery pressure was 33 beforehand, and that improved to 26. Her index went from 1.7 to 2.3, and then her CPO went from 0.7 to 1.37. Her wedge was 29, so she had both elevated left-sided and right-sided filling pressures. And I wanted to show you, or before we jump to the pictures, the distal, abdominal aorta was noted to have a filling defect on angiography. The thought is that there was a thrombus that was occluding it. Hence, we consulted vascular surgery during the case, and they felt that surgical thrombectomy was the preferred approach for management. So then after the fact, after the embolectomy, she was transferred to the OR from the cath lab, and bilateral groin cut downs and aortic and iliofemoral suction thrombectomy was performed. She also had a 4-compartment fasciotomy that was completed in the right lower extremity with concern for compartment syndrome. And it's worthy of noting that she was hemodynamically stable throughout. So I wanted to show the aortogram on the left-hand side. You see the kidneys filling up, and then just distal to the kidneys, we see a filling defect in the abdominal aorta, which was concerning for clot. And then on the right-hand side, the pulmonary angiogram with filling defects in the pulmonary arteries pre, and then the most rightward image is showing it post. So she continued to be on a heparin drip, and unfortunately, she had an increase in lethargy. Hence, she underwent an urgent head CT, which then showed a subarachnoid hemorrhage. CTA had also revealed an occluded posterior division of the right M2 segment. And for that reason, neurology, neurosurgery were consulted, and that's when they recommended that the heparin be stopped. Serial CT scans shortly after were obtained and showed stability of the bleed and the stroke. Given how high risk she was, heparin was restarted a day later, and then an MRI was completed, which revealed an acute subacute infarction within the MCA territory. Given the concern for both clot in the lungs and the aorta, there was most notably a concern for a shunt of some sort, and that is when it was decided by the ICU to pursue with a TEE. And the TEE did show normal LV function, but it did show the moderate to large size PFO. And we noted bidirectional shunting. She did undergo PFO closure roughly 7 to 8 days after her initial presentation. Her hospital stay was complicated by atrial fibrillation controlled with metoprolol. They did hypercoag workup, which was unremarkable, but they were going to repeat some of it and pursue additional hypercoag workup in the outpatient setting. And the patient, luckily, unfortunately, was discharged 22 days later in stable condition without major focal neurological deficits.
Wow, this was a spectacular case. So, Dr. Marinescu, so let's for a moment forget about the left side, which makes this case so dramatic. But so let's start talking a little bit about how you approach the catheter-directed thrombectomy with the use of thrombolytics. What particular device do you use? Have you used more than one device? Have you seen advantages in one versus the other? So let's start with that before we move to the left side.
Sure. Yeah. So I think, the treatment of pulmonary embolism is an area that there's a lot of evolution in the past couple of years. I think, like with many institutions, our practice patterns have evolved over time. And in some ways, it depends as to who's involved in the per team discussion as to which strategy we go. As was pointed out before, systemic thrombolysis is still the only class 1 indication for the management of massive pulmonary embolism. And this patient would be clearly classified as a high-risk intermediate to massive pulmonary embolism. That being said, the evolution of new devices, of which we have more than we have data, has kind of changed the game. Typically, if our medical ICU colleagues are first involved, they'll tend to shunt the patient more towards a systemic thrombolysis upfront strategy. And then if cardiology is more often involved, we'll tend to shunt patients towards a catheter-directed strategy. And if the surgeons get involved, they tend to prefer surgical embolectomy, of which we are fortunate to have all the options. It becomes really hard to know which strategy to choose. Oftentimes, our per team will involve patient-centered decision-making to help kind of shuttle patients in one direction or another. Is especially true for our intermediate risk PE, where the urgency to intervention is less. And we'll take into account aspects like, are they willing to tolerate more longer road of recovery for less upfront procedural risk, as opposed to maybe a little bit more upfront procedural risk, as we don't really know the risk in randomized controlled trials for some of these interventions, with maybe a quicker recovery or a reduced incidence of in-hospital decompensation, which we think may be the benefits of catheter-directed interventions. At our institution, we currently favor the FlowTriever, although is probably, although I have to say there is some interest in the new Bashir catheter that might be coming out, which is a combination of mechanical clot disruption with infusion of thrombolytics, kind of the best of both worlds. I think the recent Peerless 1 trial that was presented at TCT most recently suggested, interestingly, that there was not a huge difference between catheter-directed thrombolytics and catheter-directed embolectomy. There was a reduced ICU length of stay, although the trial was kind of designed to favor that outcome. So I'm not surprised that that is what they found. What was striking about that trial was the lack of difference in bleeding complications between the two arms. So it's hard to say that there's not a role for catheter-directed thrombolysis in the modern era. It's just hard to know where that is. And there's certainly been some data, for example, a subsegment of the Seattle 2 study, I believe called the 3D-RC study, that looked at which patients who received catheter-directed thrombolytics derived the most benefit, and it was those who had resolution of the small vessel obstruction, which you wouldn't be able to accomplish with a catheter-directed embolectomy approach. So I think we're still kind of in the dark as to which option is the best, but those are the options that we mainly use. We also have a pretty aggressive upfront ECMO strategy for our massive pulmonary embolisms. And we tend to be pretty aggressive at our institution about putting them on ECMO, letting them recover with anticoagulation alone for a couple of days. And then if they are unable to wean, then consider interventions at that point, and have had some success with that strategy, although it's not recommended to do that in the current guidelines.
Thank you. I'm sure that in this case, putting the patient on ECMO without obstruction of the aorta would have been particularly challenging, if not impossible. Dr. Diez, back to you. Do you have any further comments after hearing the conclusion of the case? You're muted.
Thank you. Now, just to say that the treatment approach, I think that is for a high-risk patient. I, of course, agree with this.
Dr. Colque, any final comments?
No further comments. It was amazing about the shunt. Dr. Diez was agree. Was very clever about that. I didn't see it, but very amazing. Unfortunately, we have no mechanical devices for treating that. But of course, that's what we have. Thank you.
Okay, so we have a couple of comments. I want to go back to you, Dr. Marinescu. So tell us about the issue on the aorta now. And
yeah,
surprised were you? I mean, how did you deal with that?
So, I mean, I would like to say that it was by some great stroke of genius or observation that we happened to choose upon probably the only strategy that would have worked in this person. But I think we ended up getting lucky in choosing to go with a catheter-directed upfront strategy. I think if we had gone for systemic thrombolysis up front, we could have worsened hemorrhage or complicated a embolectomy with vascular surgery afterwards. And if we had opted to go with ECMO up front, we could have embolized the clot to the brain and would have dealt with a much greater complication. So I think we ended up getting lucky there. Regarding the clot in the aorta, I mean, at this point, we had relied on our vascular surgery colleagues to help us manage that situation, and they favored an open approach, and I would have to defer to their expertise in the management of that situation. It is interesting that she ended up developing compartment syndrome. You would have imagined the clot would have been dealt with acutely enough that wouldn't have been a problem. You also wonder that maybe if you gave systemic thrombolysis, the clot may have had an opportunity to dissolve beforehand, although I don't know what the embolism to the brain would have done. Maybe that would have resolved as well before an infarct occurred and bleeding, but it's impossible to know. And many of my colleagues feel strongly that systemic thrombolysis would not be able to resolve the clot in the aorta, given its large mass and the decreased flow to that area.
Thank you. So, listening to all of you, I think, and also from the experience at our center, I think that, as you said, Dr. Marinescu, the field is evolving. And what I see is people moving away from thrombolysis. And I think in a way, this patient represents the reason why. And I would say that a few years ago, our surgeons, at least here, were much more active in terms of taking the patient like this to the operating room. But I think that what we've seen here and what we've heard from our Argentinian colleagues is that catheter-directed therapy, with or without thrombolysis, seems to be what is really taken on the field that may have not percolated to the guidelines yet. But I think it's, I didn't hear you say AngioVac, but that is another system that has been used. So I think that is probably the way that we're going to go in the next few years until something else comes up. But it seems that is the way that the field's evolving. Would you agree with that? Dr. Marinescu, would you agree with that?
Oh, yes. Yeah. Sorry for not mentioning AngioVac. It is a strategy that we sometimes use as well, especially for clot in the RA or IVC, where the larger profile of the catheter is a little bit easier to use in that setting. But I would agree. I think that the field is moving for a catheter-directed embolectomy, especially in the intermediate higher risk population. Although I think we still have questions as to, in a lower intermediate risk population, if the benefits truly outweigh the risks, as we know that probably the majority of these patients will do okay with anticoagulation alone. So we are going to incur, a cost burden. And I do worry that maybe these catheters are being adopted too liberally in a low intermediate risk population. It's hard to know where this fits in, and I look forward to seeing where the research leads us.
Thank you. I think we're going to move on, but I think that this was a truly spectacular case, and I think it lent itself for a nice discussion. So let's move on to our intermission. As I mentioned at the beginning, a very important part of this relationship has been the facilitation of rotation of trainees from Argentina to hospitals in New York State, and a number of institutions have participated as hosts, and therefore a number of trainees from Argentina have benefited from this relationship. So in 5 minutes each, I'm going to invite Dr. Pilar Domenech and Dr. Santiago Gargani, who were the two trainees during the academic year 2023-24, to share their experience. So we will start with you, Pilar. If you again in 5 minutes tell us what you did here.
Perfect. Thank you, Dr. Panza, and thanks everyone for inviting me to this join today. Well, my name is Pilar Domenech, as Dr. Panza said. I had the opportunity last year to go to Westchester Medical Center in New York City, of course, and I had the scholarship given by the Argentinian Society of Cardiology and also by the ACC. And the experience was great in a lot of aspects. I had the opportunity to go in November last year. So I spent 1 month there living in New York and also going to Westchester Medical Center. I rotated in 3 areas there. I spent a week in the ICU with Dr. Panza, and then I spent another 2 weeks, in the multi-imaging section. And also I had the opportunity to go to heart failure section. Nowadays, I'm doing a multi-imaging cardiovascular cardiology fellowship. So I think that experience was encouraging for me to do what I'm doing today. Last year, I was a cardiology resident, so I didn't know what to do after. And I think that experience helped me in that way. We read cardiac CTs and also MRI and a little bit of echo as well. And so that helped me to make my final decision. And also the ICU was a good rotation for me, because that was what I did most here in Argentina during my residency. So to see how they treat the same patients as we have here, because cardiology pathologies are the same everywhere, but with a little bit more resources maybe. And I think that was a great experience for me. And also rotating through in the heart failure section, they have like also a lot of devices regarding this, a little bit more resources that they have there, like LVAD, for example. I didn't have the chance to see one here in Argentina, and there, well, they have a lot of patients with LVAD, and well, also ECMO and balloon pumps, of course. But also, I had the opportunity to like learn how they manage post-transplant patients. We take care of that patients here in Argentina. There in the United States, I think that I've seen like more cardiothoracic surgeons taking care of them, and also the cardiologists and the heart failure team all together. And I think that was great for my experience also. And not only the academic experience, but also the social part was great, because I could meet a lot of fellows, cardiology fellows there also, and great people. And I think that the whole experience was amazing.
Thank you, Pilar. I'm so
Thank you.
happy that well, I had the opportunity of working with you, and you were really great, and I'm so happy that this helped you in your career.
Thank you so much.
And then the second trainee from Argentina during that academic year was Dr. Galgani. So Santiago, if you're there again in a few minutes, if you can summarize your experience and how it has helped you.
Okay, hello everybody. Good afternoon. Thank you for the presentations, and it's an honor to me to be a part of this meeting. I've been there 2 months of last year. I went to Montefiore Medical Center. I had the opportunity there to rotate in advanced cardiac imaging, and I did some research. It was a really important thing to me, because it was so many times that I desired to went there, and it was amazing. I think that the experience could enlighten me and enhance my skills, not also in my professional development, as my personal development as well. New York, it was an amazing city, and I want to emphasize the importance of this program, because we can to open our networking, and also we could build relationships. It's really important for us, and without any doubt, we need to do this kind of programs. So it was a really good time. I'm really grateful for the opportunity, and also I had the opportunity to work with some AI programs. That it was a kickoff for me to start now to doing some postgraduate training in AI and healthcare. So it was really good. So once again, thank you. I could make so many relationships that for sure could improve my professional work as my develop in the cardiology file. So it was good. So great.
Thank you, Santiago. And again, I think that these two trainees are a testament of the importance of this program. Dr. Marinescu, do you have a comment? I see your virtual hand.
That was a clap, not a comment.
Okay. Yeah, so this program, and by the way, for those of you who may not know the origin of this, this started many years ago with an intention from the Central American College of Cardiology office to have pairs of domestic chapters with international chapters. And it was by coincidence or by decision of someone that I don't know, but it wasn't me, that paired the New York chapter with the Argentina chapter. And so me being from Argentina was a natural thing for me to help with this relationship. And by now, I think we have probably close to 10 trainees that have rotated through New York hospitals. And we have 2 more coming this academic year. All right, so we're doing well on time, which makes me happy and makes my job easier. So we're going to move on to now the presentation from Argentina. We're fortunate to have Dr. Rocío Baro Vila from the Instituto Cardiovascular in Buenos Aires. do the presentation. So Dr. Vila,
okay,
please
thank you
go ahead.
so much. Can you hear me?
Yes, yes.
Perfect. Good afternoon, everybody, and thank you so much for giving us this time to discuss the case. This may not be as spectacular as the previous one, but I think it's fun to just discuss different cases. So I will start with this patient. We first met him on April 2015. He was at that time a 61-year-old patient. He didn't have any cardiovascular risk factors. He presented with a history of moderate effort shortness of breath of several years, and he was diagnosed with what he called ventricular hypertrophy 4 years ago. He reports effort-related shortness of breath. He was in New York Heart Association Functional Class 3, and he also referred some chest discomfort during exertion, as well as dizziness when walking at a fast pace. His brother was also under evaluation for hypertrophic cardiomyopathy, and his physical examination revealed a normal blood pressure of 130/80. His heart rate was 65 beats per minute with a regular pulse, and he also had a systolic ejection murmur in the aortic area, which increased with the Valsalva maneuver. He was medicated with 10 milligrams of bisoprolol each day, and he was first referred to our institution by an external physician for an ICD implantation. If we can, yeah, thank you so much. So he brought a bunch of prior studies. Among them, we have this Holter ECG of 24 hours, where, as you can see, we found just one episode of a short VT. His mean heart rate was of 67 beats per minute with without any other further findings, sorry. His regular ECG shows a normal sinus rhythm. He was at approximately a heart rate of 60 beats per minute. Sorry, his PR segment was almost 200 milliseconds. His QRS complex is not wide, but as you can see, he does have an abnormal repolarization with negative T waves, especially in probably the lateral leads, and he also shows some signs of left ventricle hypertrophy. He also brought a 6-minute walking test that where he could achieve 337.5 meters. He had to slow down due to shortness of breath after 2.5 minutes, and then he had to stop for 10 seconds at 3 minutes, and then he could restart at a slower pace. And probably the most interesting study he brought was this echocardiogram that, I don't know if you can see the clips moving, but we have these apical 4 chambers and 3 chambers view, where what catches our attention at first is the increased wall thickness. Most of the walls are thickened, but especially the basal septum area. And yes, thank you. And then you can see when we put some color Doppler over the areas, you can also see this mitral regurgitation. It was reported to be of moderate to severe grade, and the mechanism was described as double. He had some anterior systolic movement, and also it was described to have posterior leaflet prolapse. So I don't know if you can see in these images, but he has like the 2 mechanisms and probably 2 MR jets. The next one, please. Thank you. So these are just some like pictures for you to see in more detail if you want. But on the left side, you can see the septal wall thickness that is severely increased. It gets almost to 30 millimeters in the basal septum. He also has an impaired or abnormal diastolic filling pattern. The left atrium doesn't seem to be much severely enlarged, but it's not normal. And then here you can see that he does have some left ventricle outflow tract obstruction with a gradient that is in the left side. You can see the gradient at rest, which is 51, and then it increases to almost 99 with the Valsalva maneuver. He also underwent an stress echocardiogram where he had a normal blood pressure behavior. He did complain of exertional dyspnea, but didn't had any arrhythmias during the study. And as you can see on the right bottom of the screen, the left ventricle outflow tract gradient was of 81 at rest, and then it increased to 97 with Valsalva, and it got up to 160 on exertion. So to continue with the case, finally, the ICD was implanted for primary prevention of sudden cardiac death. He also underwent a genetic testing that revealed that he had a pathogenic mutation in the MYH7 gene. At that time, the patient remained symptomatic and New York Heart Association functional class 3, so verapamil was started. That resulted in a very slightly clinical improvement, and he was suggested to undergo a septal myectomy surgery, but he was not very comfortable with that decision, so he took a few years to finally make the decision to go to Mayo Clinic and finally have transmitral myectomy and mitral valve repair surgery. He came back to Argentina to continue his follow-up at our clinic, and you can see here, this is the echocardiogram after the surgery, where, as you can see, of course, the thickness of the walls are still increased. He still has some mitral regurgitation, which was reported to be mild to moderate in this case. It's okay, you can go to the next one, please. Sorry, yes, thank you. And the septum was measured to be 21 or almost 22 millimeters. His ejection fraction was still normal. It was estimated to be around 64%. He also had this, as I mentioned before, a dilated left atrium. I think we can skip this one. And yeah, so you can see here in the right, the most interesting findings probably, as you can see, he still has a remaining left ventricle outflow tract gradient of 73 at rest, and it increases to 180 with the Valsalva maneuver too. This is the global longitudinal strain that, as you can see, it's abnormal mainly in the most affected or more thickened areas. So the patient, as I said, was still symptomatic. He experienced 2 episodes of AFib after surgery. So he was under treatment at this time with verapamil 360 milligrams, atorvastatin 20 milligrams. He was anticoagulated with apixaban, and then he was given amiodarone temporarily, but he had some thyroid problems. He presented hypothyroidism, so it was decided to stop amiodarone in this case. So since he was still symptomatic and he was still complaining of shortness of breath and some chest discomfort, he expressed a desire to improve his symptoms.
All right, thank you. So let's stop there. Quite challenging case. We are fortunate to have today Dr. Srihari Naidu. I'm fortunate to have him in my department, but we're fortunate to have him today as he has been a writer of the guidelines and he's an expert on this condition. So Hari, welcome, and what are your thoughts? So this patient has clear hypertrophic cardiomyopathy with obstruction, goes to the Mayo Clinic and comes back to Argentina. And it seems like he still has the same degree of obstruction.
Yeah, so a great case, great presentation. Thanks for bringing it to us. There's a couple thoughts here. One is the ICD made sense. I think I had VT, significant duration of VT it looked like, and the septum was almost 3 centimeters, so that was good. So you already have a device that can pace you, which is good. Then when you look at the initial images, it was fairly focal basal hypertrophy, but very significant and very significant gradients. So the larger the thickness and the larger the gradients, the more they tend to do better with myectomy. And in addition, since there was potentially some intrinsic mitral valve involvement, mitral surgery in conjunction with the myectomy does make sense. And it's interesting to me because they almost never touched the mitral valve in Mayo. This was Mayo Rochester? This was Mayo Rochester? Oh, Mayo?
I'm not sure. I'm not sure. Sorry about it. I don't have exactly the geography.
Okay. So they tend to not do anything with the mitral valve, but in this case they did. So the patient got a myectomy and the mitral valve. On the images you show, the teaching is usually that you do the myectomy. First, it should be thinner than that because it looks like there was still 2.2 centimeters even where they cut. And usually they do the myectomy parallel to the RV down to the base of the papillary muscle. This looks like it didn't go down to the base of the papillary muscle, but went kind of to where the papillary muscle inserts. And that is why there's still residual obstruction more distally in the ventricle. I've seen this before, and we've done maybe I've done 10 post-myectomy alcohol ablations, and usually they are more challenging because you have to find usually a second septal perforator. It's usually not the first septal perforator. And so they're a little bit more challenging to hit the mid-ventricle, or the alternative is to go back to surgery, which I'm sure the patient is not keen on because of the fact that they're further away. The other option that you could do is medications such as Norpace, which might be good to prevent AFib in this patient, but also to decrease the gradient. I think it can help in both of those situations, but again, it's another medication. The other option is mavacamten. Mavacamten can work and will probably eliminate the gradient in this patient. But I don't know what the situation is in your country for mavacamten, but it's quite costly here if it's not covered by insurance, so that's an issue as well. Finally, there's the issue of apical pacing. If you do, if the ICD lead was placed at the apex, you have the opportunity to pace the ventricle. And we believe that pacing chronically in a subset of patients, usually older patients, may reduce obstruction both from initiating dysynchrony, which may help. And this is not extremely basal anymore, but it may help. But also, we have found that probably the slight hypocontractility that chronic pacing develops or promulgates results in a decreased contractility and overall lessening of the gradient. Probably that takes about 6 months to 12 months to see. So those are the thoughts I have. It's unfortunate because we like to think that when you have either alcohol ablation or myectomy, you're not going to need the other procedure or other procedures. Certainly, after myectomy, it should almost never require a second procedure if you eliminate the totality of the gradient. I think in this case, it was not done as deep and as long in terms of the incision, and that's why we had this result. Those are my thoughts. Julio, what do you think, Dr. Panza?
Yeah, I wanted to ask you, I mean, you've been very involved with the early use of mavacamten, through the trials, and the endpoint, if I remember correctly, was the need for a septal reduction therapy, right? And please correct me if I'm wrong, but I think the trial was designed in such a way that it was mavacamten or placebo, and how many patients got off the surgical or alcohol ablation list.
Right.
So, which basically means mavacamten before surgery. So, have you had any experience yourself or through communication with others about using mavacamten not before surgery,
but afterwards,
but like after surgery?
Actually, I have quite a bit of experience now because, as you know, we do a lot of patients with mavacamten. It's probably at least 5 of them now, either after myectomy or alcohol ablation, that have some residual gradients. And oftentimes you can give them a small introductory dose of mavacamten and those go away because usually the gradients that are residual can be easily eliminated by this. Now, it's not ideal because you try to do something and now you do something else. But the patients who I've placed on mavacamten after separation therapy have done very well. I've not had problems. I will say that there is some data that patients with AFib with mavacamten may have worse outcomes because if they are on mavacamten, which causes some decreased contractility, and then they go into AFib, there's been a higher incidence of heart failure in those patients. So I'd like to see that the AFib burden went down or is minimal. But I think this is a growing role for mavacamten, which we would say is, I guess, off-label. Actually, if they continue to have obstruction, it's probably still on label at some point. So I think that's okay. I think it will be a growing indication for mavacamten in patients who have residual obstruction who do not want to go for another procedure. That being said, before mavacamten, I would accept about a 5 to 10% rate of redo alcohol ablation, because we try to do as little ablation as possible to get the desired result, knowing that if we give too much alcohol or multiple septals, you increase the pacemaker rate or you increase the complication rate. And so we will oftentimes say, let's do what we can to concentrate on balancing safety and efficacy, and then wait 6 months and see if the patient could get a second ablation. Now, those patients during the waiting game, if I think they could require a second ablation, which, by the way, all the patients I've done a second ablation on have all gone to NYHA class 1. I can't remember one that has not. But instead of that, you now have the option of mavacamten. I will say that pretty much all patients choose mavacamten over a second ablation in the interim where this drug was approved. So I think it gives you an idea that people, if one medication can do the trick, they're okay with it.
Thank you. So let me go back to Dr. Diez, who is from the same institution. So one thing I would like to hear is, this patient, I don't want you to tell us what happened next yet, but let's go back to the beginning of the case. So is there any center in Argentina that is doing myectomy now or alcohol ablation? Where is the landscape in Argentina for the interventional treatment of hypertrophic cardiomyopathy?
Yes, we have some centers that are performing myomectomy. In our center, we have more than 150 cases with 0.8 of mortality. And well, I don't know the result of another centers, but I assume that they are good. So we have the possibility to perform myomectomy with good results. And alcohol ablation is a technique that in our country is decreasing. The use is decreasing. And now we have some months ago, we access to mavacamten with really some financial troubles, but well, we have mavacamten.
Okay. Dr. Colque, do you have anything to add? What about in Cordoba? Is there someone doing myectomy or alcohol ablation?
Okay, we have more experience with septal ablation. Of course, we have to choose the patient with a particular first settle or second settle with a large size, but very few cases. Septalmectomy, only 2 cases, very directed, very chosen. We have no more experience, zero mortality, but only 2 cases. We have not to talk about mortality. Only experience with mavacamten is in protocol. We have not the chance, like Dr. Mirta said, that the cost travel here in Argentina for financial coverage. I made a question by the chat. You, doctor, mentioned apical pacing. What cases do you choose? Do you decide apical pacing, if you can allow the question?
Yeah, so sometimes we'll do apical pacing in an older patient who cannot tolerate much beta blockers, so that if you think that increasing beta blockers would be worthwhile to alleviate latent obstruction, then having a pacemaker implanted and then increasing beta blockers helps. The other thing is, in the empathy trial, it seemed to be the patients over the age of 65 that had some benefit. It's a subgroup analysis of that trial. So in older patients with focal hypertrophy, with the rest of the muscle not too hypertrophied, we can oftentimes decrease gradients. We're doing a study right now internally, an IRB study, where we're pacing in different areas. Dr. Panza knows about this, and we have also preliminarily found that apical pacing seems to decrease gradients to some extent in these patients as well. It's not a very robust mechanism, so it's one of these things that the tried and true solutions are septal reduction therapy, mavacamten. But if you have a reason to hedge, meaning there's a patient who's older, wants to avoid some of the risks of invasive therapies, and apical pacing might be a good option in between moving on to these other options.
So Hari, let me push you a little bit. So now you have this patient. I heard 4 options: redo surgery, alcohol ablation, mavacamten, or apical pacing. Now this is your patient. What would you do?
With my patient here, I would probably try mavacamten on this patient first for 2 reasons. One is that it looks like with this ejection fraction, you should be able to eliminate the gradient without causing heart failure, number 1. And in doing that, you can then reassess symptoms and see if the residual NYHA class goes away. Then you know that the mechanism of the NYHA class reduction was a reduction in the gradient. So that would be helpful both to show you that the patient is getting better from relief of obstruction and to get the patient better. And then they can decide if they want to maintain on that medication long term. As you guys all mentioned, it's a logistical difficulty. They have to have an echo in this country every month and then every 3 months after that. And about 10% of the patients I put on mavacamten ultimately come off mavacamten. Not everybody ends up staying on it. We've been doing it 2-3 years now. And so there are patients who have problems with it, or can't tolerate it, can't follow through, and we have to stop it. So it's not a long-term solution for everybody. And so, but I think I would probably do mavacamten in this patient first. Here.
Okay. Thank you. So, Dr. Vila, why don't we go back to you and tell us what happened?
Okay, sure. So,
if I may, the other thing I might do is repeat the cardiac cath to look at the coronary angiogram just to see, is there a second septal? Is there opportunity for alcohol ablation? Obviously, surgery is also another option, but it's a hard sell to a patient to go back to open heart surgery. And of course, the risks are much higher for the second time for an invasive sternotomy. So sorry, go ahead.
Okay, no, thank you so much. I mean, it's an honor for me to be listening to you, giving your opinion on our case. So thank you so much. In this particular case, as you mentioned, this patient was not willing to undergo surgery again. He was very well educated about his disease. So he had made his own research about mavacamten. And so he was willing to wait till mavacamten was back in Argentina, was like in the market in Argentina to trial. So in this case, we decided to put him on a mavacamten starting dose of 5 milligrams, and then we didn't have much experience, so we decided to like lower the verapamil dose slowly. So just for you to remember, this was the pre-treatment echocardiogram, where you can see an ejection fraction of 64% and the gradients that were 73 at rest and 118 with Valsalva. This was the first echocardiogram that we performed after he started mavacamten. This was 28 days after treatment. I don't have much to say about them. Then you can see here in the apical 3 chambers, and then with color, maybe you can see a slightly improvement in the MR and also the velocity at the outflow tract. And the ejection fraction was estimated to be of 57%. So it had dropped a few points from the baseline one that was, if you remember, 64. And then probably the most interesting findings are about the gradient. You can see 2 resting gradients in the lower part of the screen at the left side. 2 of them, one estimated to be 9. And then on the right side with the Valsalva maneuver, it increasing to 14. So non-significant gradients. So the patient reported a clinical improvement to New York Heart Association Functional Class 1, almost 2. So gradually we decided to discontinue verapamil, and then the mavacamten dose was reduced to 2.5 milligrams daily as a maintaining dose. And this was the last echocardiogram we have. That was performed 50 days after starting mavacamten. You can see the ejection fraction being estimated of 61%. And the gradients being of 12 at rest and 25 with Valsalva. So by now the patient is just slightly symptomatic due to some effort-induced shortness of breath, but he really reports a significant improvement on his symptoms, and he's currently under this 2.5 milligrams daily mavacamten dose. And I think
thank you. So, I mean, I think that this was as spectacular a case as the first one. Since we're doing well on time, let me go back to Dr. Naidu. So, Harry, wasn't there the initial dose 2.5 and then progressing to 5? No. Is that what you're doing now?
No, so the insert and the way the trials do it is they start actually at 5 milligrams, but you can go down to 2.5. What they suggest is you start at 5 milligrams, and it takes about 3 months to reach a steady state. Some people are faster responders than others, so some people have an early response and some people have a later response. But by 3 months, everybody will plateau in terms of their clinical objective and subjective findings. That being said, some people will have either a drop in EF or the gradient is eliminated very quickly. In those patients, they tend to recommend dropping the dose to 2.5. I have not done that in my experience. What I tend to do is what you guys did, is eliminate the other medications to see if I can tolerate the 5 milligram dose and less of the other medications. And then only go down to the 2.5 if I feel like the EF is borderline. On the first echo you showed, it didn't, you said 57% EF, but EF looked a little sluggish to me, and I was a little worried about that. So I would have, I'd done the same thing, eliminate the verapamil, everything else first, and redone the echo. Looks like they did well on that, and then you did drop it to 2.5. Sounds like the patient's doing well, but I suspect there's still probably provocal obstruction in that patient if you really provoke them. And so it's one of these things that you're kind of managing, but it's not perfect, but it's kind of managing it okay right now. But to answer your question, Dr. Panza, they start at 5, and then after the 3 months, you make a decision, or any time course, you can make a decision to go down. But if there's persistent gradient and the EF remains over 55, you can also go up on the dose, but more clinically driven. Typically, if they have gradients but they're feeling good, you can leave it alone. But if they have gradients and they're feeling poor, you can increase it. But going from 5 to 10 is a big jump from what I've seen. And so I am a little wary of it unless they have really nice ejection fractions of 65 to 70% still.
So to continue drilling on your expertise, so looking in the long term, let's say that this last slide was from yesterday, meaning that now the mavacamten dose has been decreased to 2.5. How long would you recommend to keep it at 2.5? What further studies? I think you mentioned something about having a mentality of maybe this stopping the mavacamten at some point, and how would you be guided to do that?
Yeah, currently nobody is stopping the medication. They're keeping it going. Here we do every 3-month echo to make sure the EF is staying over 55%, and to make sure the gradients are still controlled, and to reassess symptoms and other drug-drug interactions. If they're doing well, you just keep them going. What really happens is that they call with some illness. They call with a cold, they call with some other thing, they have some surgery, or they're short of breath from something else, and then you're not sure what's going on. And so you have to bring them in rapidly to get an EKG and an echo to see, are they in AFib now? Is there some other intercurrent problem? What we're worried about is if they have some other intercurrent disease, even a cold or some other major infection in the body, will the EF drop while the patient's on mavacamten? Mainly because, like you see in sepsis and other things, there could be some cardiotoxic effects of that, or cardioinhibitory effects. And does mavacamten potentiate those things? It does appear that at least we're very concerned that that may happen. In the United States, there's a warning that with major intercurrent illness, there may be a drop in ejection fraction or heart failure symptoms. So we are concerned about that. And in my experience, I have had a few patients that have come in with COVID or something else, and then the ejection fraction is 30%. And so I've had to stop the mavacamten completely, repeat the echo in a month, and then decide if I want to go down the dose or stop it completely. So while the medication has helped enormously, it puts you in a stage where you're kind of watching these patients and kind of concerned about if anything else happens in their life, does the heart then decrease function during that episode? And what is the frequency of that happening? If that happens a lot, that's going to put a damper on these medications. If it doesn't happen that much, then it won't, or we'll just get used to it happening relatively rarely, which is the case right now.
Thank you. Dr. Diez, any final comments about this case or in general about the use of mavacamten?
Now, about the use of mavacamten, we are just learning because we have experience related to protocol patients, and now we are hoping to use in a more with more patients.
We do feel that aficamten, which is the second I don't know if a second generation, but it's a second in the same class. They just had a announcement from the FDA that they probably will be available later this year. They were put through channels that look like it's going to be available, not this year, available early part of 2025. So that will allow a different agent with a shorter half-life. Looks like it takes 2 months to kick in versus 3 months to kick in, and potentially less drug-drug interactions. But so we'll have more options, which hopefully will allow, because the nuances between the two medications, maybe a wider, broader patient population.
Dr. Colque, any other comments?
No further comments. Of course, we, as Dr. Diez said, we are waiting for more broadening use of myosin inhibitor, because apparently they are the solution. Better result, more better result than the other alternatives, more aggressive. Thank you for the question.
Thank you. Dr. Marinescu, any final comments or questions?
No, I mean, it's just, it looks like both of these fields are areas that have a lot of evolution, and I'm just happy to be part of cardiology, where we have so much growth and things to look forward to in the future.
Yeah, I was actually going to make the exact same point. I mean, two completely different cases, but in the end, there's always some commonality. And in this case, we're showing how in both the PE case and the HCM case, how the field is evolving from whatever we were to something that is new. And these drugs, we're going to have to see about aficamten, but certainly mavacamten has been a game changer. I mean, we have seen it in our institution, a reduced number of septal reduction therapy patients because of that. So let me conclude here. I'm very happy that we stay on time. I want to thank all the presenters for the spectacular cases, the great discussions. I think that this has continued this tradition that we now have established of exchange of information, seeing how things are done differently, and how we can help each other, at least intellectually, in terms of the discussion. I would be remiss if I didn't thank Carolina and Taylor for their great support, and Marina Joseph from the Argentina side, and all the leadership on the Argentina chapter as well. So thank you very much to all the participants. I hope you enjoyed this. And certainly we have now kind of established the first Wednesday of December. And I think that we will welcome all comments, but I think that this was successful, and I think we will continue doing this every first Wednesday of December. So thank you very much. And with that, I will conclude this webinar.
Thank you so much. Thank you so much.
And thank you, Dr. Panza. Great session.
Right.
Thanks, everyone.
Thank you, everybody.
Thank you.